This segment is brought to you by CRPS Warriors Foundation. Ladies and gentlemen, please take your seat. The show is about to start. Hey guys, what's up? This is Phoebe.
This is Mike.
This is a Mike and Phoebe show, episode 16 for the CRPS Warrior Foundation series. Thank you so much for joining us. We are airing today, April 8th, 2023. And for today's episode, we are so honored to have Dr. Peter J. Bergman joining us from the Bregman Foot-Ankle and Nerve Center out of Las Vegas, Nevada. Hi, Dr. Bergman.
Good morning. How's everybody doing?
Good. How are you?
I'm doing great. Yeah, just got up here, had my first cup of coffee, so I'm raring to go.
Awesome. Now, Dr. Bergman, he is the past president of the Association of Extremity Nerve Surgeons, as well as board certified by the American Board of Foot and Ankle Surgery. So we're so happy to have you join us today.
I'm very happy to be here, and hopefully I can enlighten your audience and spread the word about not only complex regional pain syndrome, but also some other nerve issues that I think are often overlooked by not only physicians, but certainly the general population.
Yes, absolutely. Now, why don't you tell us about how you became involved with the CRPS Warriors Foundation?
Well, turns out that one of my patients knew the current president of the Warrior Foundation, Deborah, and she said she was actually my former medical assistant who went on to do other things. But she said, "Hey, I have this friend, and she's got CRPS, and no one's really been able to help her out too much. And I thought, given your background, maybe you would want to see her." And I said, "Sure, I'd be happy to do that." And ultimately, Deb came to see me, and, she certainly is sort of your classic CRPS patient who has this pain that just doesn't ever go away, really. And she's had a lot of different treatments, and I said, okay, well, we'll see what we can do. And so basically, I just did a bunch of different stuff with her clinically with some treatments, and just recently actually just performed surgery on her, putting in a peripheral nerve stimulator.
Ah.
Yes, she did mention that. And I'm so happy that she has you as a connection, not only as a CRPS Warrior Foundation resource, but also as her doctor, because that's so important to have someone who is very knowledgeable in that aspect. So I'm happy that you guys are in that connection.
Yeah.
Yes.
It was one of those, kismet things.
Yes, definitely agree with that. Absolutely.
So where are you actually calling in from? Just, for everybody to know.
Oh, so I'm just outside of Las Vegas proper, hanging out in my house this morning. And, my office is located probably about 10 to 15 minutes from the Strip in Las Vegas.
Ah, nice. Very nice.
So we've probably passed by it a couple times when we were in Vegas.
More times than what we know.
Yeah.
Don't worry. What stays in Vegas stays in Vegas.
There you go.
Now, can you tell us about Morton's neuroma and your quest to put in, and you put it in my emails. Can you tell me about your goal about Morton's neuroma and what you plan on doing or hope to do?
Sure. So first, let me define what Morton's neuroma is, right? So everyone knows what that is. Morton's neuroma was actually a description by a guy named Morton, who was a foot surgeon way back when. And actually, he was actually the second person to describe this disease process or entity process where one of the nerves, the interdigital nerves in the foot, and it's usually between the third and fourth toes, and then secondarily between the second and third toes, where the nerve actually becomes swollen, it gets a lot of scar tissue around it, and it can become very painful. And initially, this guy, Morton, called it Morton's neuroma, or it was named Morton's neuroma after him. And it really is, we like to laugh, it's a misnomer for the misneuroma. So it implies that it's a tumor, and it really isn't a tumor. It's an entrapment syndrome, just like carpal tunnel syndrome is in the wrist. So this condition occurs because there's a ligament, the deep transverse intermetatarsal ligament, which sits on top of that nerve. And when you walk, that ligament rubs on that nerve and ultimately starts to create an entrapment syndrome from repetitive overuse. And the nerve can become larger, triple, quadruple the size that it normally is because of all the scar tissue that forms around that interaction between the ligaments. So what did people do for it? Certainly they treated it conservatively for quite a while, but when conservative therapy fails, and unfortunately with this condition, it probably fails more than it succeeds when someone has it really full blown, and the symptoms are typically like a burning in the ball of the foot, specifically around the third and fourth toes. And you have this sometimes radiating, shocking nerve pain that happens in the toes. And people will describe walking on a marble. Sometimes they'll say their socks are bunched up under that part of their toes. And so if you diagnose it and treat it, you understand this condition really well. And so I've been treating this for a really long time. And initially when I learned how to surgically treat this particular problem, we would cut it out. We would do a neurectomy. Basically going in usually from the top of the foot and taking a scissor and just cutting that nerve and letting it retract into the foot, and hopefully it would sort of die down, peter out, and never bother you again. The problem with this procedure is that there's a reasonable chance, somewhere between 10 and 30%, no one really knows the exact numbers, that you're going to get a stump neuroma after you cut that nerve. What does that mean? Well, anytime you cut a nerve, it wants to grow back. When it grows back, the little axons, the little nerve fibers that come out from it, try to attach to something because that's what they did before. And when they try and fail, they become painful. And when they become painful, and this can even lead to complex regional pain syndrome, I'm very sure that people who've had neurectomies have gone on to develop. In fact, I know a couple of patients who had complex regional pain syndrome. One in particular was one of the most interesting cases I've ever seen, where this poor woman had a neurectomy done, and she developed these tics in her head and her neck, and just had this chronic pain that never went away. And to my knowledge, I don't think it ever went away to this day. So that was one of the most extreme situations of where someone went in to have a neurectomy and came out, and it really ruined their life. And I've seen that numerous times. So doing this neurectomy is not without significant potential damage to a person's life. And unfortunately, I think a lot of surgeons don't really understand or see the ramifications of that, and they assume it's sort of a benign procedure. Well, they'll just cut the nerve out and hope for the best, and maybe a lot of their patients get better, but there's a better process. And so what is that better process and better procedure? And that's decompression. And again, just like in carpal tunnel surgery, what we're doing is we're making a little incision on top of the foot, going down to that ligament, just like the carpal tunnel ligament, and we're cutting that ligament. And when you cut that ligament, it's no longer compressing the nerve, no longer rubbing on the nerve, and now that nerve is free to heal itself, and certainly that will happen over time in at least 80% of the cases. My success rate seems to be somewhere in the 90 percentile. We do a little extra things here and there, and certainly my microsurgical training is helpful in that diagnosis. So I don't think anyone can just go dive in and do decompression without having proper training. But the whole point is to preserve the nerve. There's really no reason to primarily go in and cut that nerve initially when you have decompression as an option, because decompression cannot make you worse. Sure, you can have a normal complication of an infection or something like that, but decompressions really cannot make you worse. You'd have to, I've done over 700 of them, and not one of my patients that I've done it on has gotten worse from a decompression. And the number of people I've had to go back in and actually cut the nerve out is probably less than 5%.
Wow. So now, is decompression a relatively new procedure or that you've discovered, or is this, maybe a little older procedure? How does that come about?
Yeah, so it's probably about, in this country, which is really where it was sort of generated from, it's probably about 20 years old at this point, where there's a medical doctor named Lee Dellen who sort of, I don't want to say pioneered, but he was the tip of the spear in promoting decompressions because he's a hand surgeon by training, as well as a plastic surgeon, and I think he just retired. And so he actually set up a workshop for surgeons to come and learn how to decompress things. And so him and others have really brought this to the or attempted to bring this to the forefront. And that's kind of where the Association of Extremity Nerve Surgeons came about because he had his own thing, and then we decided as podiatrists that we're going to also create an entity where we can train other doctors to recognize and treat this using this technique. And so, but today, I would say predominantly doctors are still cutting that nerve out, certainly outside the United States a lot. But even in the United States, the nerves are still getting cut out, and it's really a disservice to the patients, because if they don't understand or know what decompression is, they're not going to offer it to their patients. And I've had plenty of patients who've been told by other doctors, surgeons, mostly orthopedic surgeons, that, oh yeah, that doesn't work, or, I tried it and failed, so it's a waste of time. And that's just not true. It's just those surgeons never took the proper training and never really took the time to understand it and think it through. This is a totally different subject here, but it's kind of like what happened to me a couple of months ago when I was listening to another podcast in the medical field with a colleague of mine, and he had a gentleman on there who basically dispelled the idea that putting ice on everything after surgery or after an injury is really not a good idea. Ice actually retards the healing process. Yes, it may help with some temporary pain relief, but it doesn't do anything to help your swelling go down or your pain or long-term recovery process. So for me, I had to make an adjustment in the way I treat my patients, and so now I've shifted to really eliminating ice from the use of my surgical patients.
Oh, wow.
Wow.
See, and I'm not a medical professional at all. I'm just a regular person. So, what I've been brought up to know is that ice would, heal a little bit, bring down the swelling, but then not use ice all the time. So, that's just, I guess, common knowledge. But now things are different.
Yeah, or even use a combination of ice and heat at the, off and on.
Yeah, that's called contrast therapy, where you're using the ice and heat, which I still use in my practice. I'm sort of hanging on a little bit, and some patients really want to use that ice. And so I'll say, that's fine, let's at least lower the amount of ice we're using and put some heat in there to use with the ice. And, I guess if someone wants to use ice for like a day or so, well, I'll even tell my patients, if you're going to use ice, if you're in a lot of pain, you want to use some ice, go ahead. But as soon as it goes away and you feel better, get off the ice. I used to say the complete opposite of that, where I would say ice your leg round the clock for the first 2 days after your surgery, and now I don't do that at all. So we'll see how things go over the next year with me doing that, and if it really dynamically changes the way my patients respond and hopefully heal better.
Oh, yeah, that's true too. And I know for myself, for when I get back pain, I can't use any heat because it makes the pain even worse. Now, if I use ice, then it takes the pain away for, at least 5, 6, maybe 7 hours.
Yeah. Again, I'm one of those, ice guy. I have a bad back myself sometimes, and I'll put ice on it, and sometimes heat can exacerbate it. And different treatments for different people too. Like I said, I'm not tied to that 100%. I'm not going to be, not dogma to me, but I'm, again, just working my way through this concept. But as it pertains to the Morton's neuroma, there really is no reason to go in and primarily do a neurectomy as a primary surgery for this condition. The only real rational, I don't even want to say rational, the only irrational reason to say, well, if you have two choices, right? You have choice A on the left is neurectomy, which has probably about let's call it a 75 to 80% success rate, but you have a 20% chance of getting significantly worse with that procedure. And then on the other side, you have decompression, which let's say will give it the same success rate, even though I think it's probably a little bit higher. It also doesn't denervate the area, so it's not causing numbness. When you cut a nerve, you're losing that sensation. But that choice B of decompression has a near zero chance of making you worse. So why would you choose A if B is available? And the only real answer is, well, if I do B and it doesn't work, then I have a problem, right? Because it didn't work. Well, yeah, but you also didn't get worse. But now you can decide whether or not you either want to live with the problem or go have that neurectomy that you wanted to, was an option to begin with, because you didn't burn any bridges. Once you cut that nerve, you burn that bridge, and now you're dealing with issues, and you have to do a much bigger surgery to deal with that problem.
Yeah, so let me ask before we go to the next question. Is cutting the nerve out more invasive than actually just taking a decompression off?
I believe it is, actually, yeah. And let me just add this little note in there that nowadays, instead of just cutting the nerve and letting it fly, if you will, a lot of surgeons will cut that nerve and try to bury it in some muscle near the area, or they'll put something on top of it. We've all tried to put things on it to keep it from growing back and creating a stump. And there is a product out that you can use now that's a little cap that you can tuck the nerve into. And that's been out for probably about 3 or 4 years now, and seems to be having good results. But still, I don't think it's a good idea to be cutting the nerve when you don't have to do that. So the decompression, it just requires a little bit of extra training to understand the little nuances of what you're doing. And it can even be done endoscopically, where you're just doing it through a tiny incision. I think the success rate's probably a little bit lower when you do it that way, but it's probably still consistent with the success rates of neurectomy, if not higher.
Very nice.
So now tell me about the restless leg syndrome, how it can be cured with the nerve decompression surgery sometimes.
Yeah, so restless leg syndrome is one of those sort of unknown entities. There's been a lot of stuff written about it in the scientific and medical literature. However, none of it is conclusive as to even what causes it. Many people write about it's a vascular problem. Some people write that it's a neurological problem. Some people write it's a psychological problem. Is it a combination of all of them? Probably. And so there really is no cure for it if you ask neurologists who treat it. And the reality is that since I've been involved with the Association of Extremity Nerve Surgeons, I've been exposed to other surgeons and now myself where I've treated people with restless leg syndrome, and they get better if you can identify the nerve entrapment, because there's multiple areas in your leg that can be entrapped by nerves, probably about 5 or 6 different areas that are commonly entrapped. And if you can identify them and release them, there's a fairly good chance that if someone has restless leg syndrome, it will get better. And one of the sort of light bulb moments for me was probably about 10 years ago or so. Excuse me. I had a patient who I did not know had restless leg syndrome, and I did a surgery on them to decompress their nerve because they told me that they were having pain. I didn't know that every night he slept in his not in his wife the bedroom by himself, because he was jumping around so much in bed that his wife couldn't sleep in the same bed with him. So after the surgery, he told me, I want to thank you for the surgery. And I said, yeah, no problem. I'm glad you're doing well. I said, no, you don't understand. My restless leg syndrome is gone. I've had this for 30 years.
Oh.
And I said, what? He said, yeah. I said, I didn't even know you had that. He's like, yeah, I didn't even think you dealt with that or whatever. I just had to live with it. And so that allowed me to sort of, I'll tell you an even more interesting story in a second here. So that allowed me to sort of validate what I had already heard from other people, that this works. And so, there's probably hundreds of thousands of people in the world suffering with restless leg syndrome that don't really need to. And I'm not saying you certainly can cure everybody, but I would say at least 20% of those people can be cured with surgery. There's been articles written on this. And
wow,
what most people get treated with restless leg syndrome are these horrible drugs. That have horrible side effects, and when you try to come off of them, it's very difficult. And so I'll just touch on one more thing that a patient interaction that I had. This is now right when COVID was happening. A gentleman from Australia contacted me. He's about in his late 60s, and he had been living with restless leg syndrome for 30 plus years, and nobody could treat him. And he was on these multiple medications just to allow him to get 2 hours of sleep a night. Every night he'd try to go to bed. He couldn't. He'd have to go outside, walk 3 miles, come back into his house, tire himself out so he'd get a couple hours of sleep, meanwhile being on all these medications. And so we did a telemedicine consult. He was in Australia and I was here in Vegas, and we talked for about an hour. And after talking with him, he said, Dr. Bregman, I want to come see you. After talking to you, I want to come see you and see if we can help me out with your surgery. So he came to town, right when COVID hit. So it's a little trouble getting over here. And I examined him. And what my natural training said is that you have to find these particular findings in order to fix this problem. And when I examined him, he certainly wasn't classic, and I didn't feel very confident about him getting better. But he had traveled all this way, so I felt really bad. And I told him straight out, I said, listen, I don't see the classic signs of nerve entrapment here, but because this restless leg syndrome is so bizarre and unknown, and there's a vascular component to it, I know that when I do this surgery, we're going to increase your blood flow because we're taking the fascia, the constriction, not only from the nerve, but also the blood vessels because they travel together. And, we can certainly do it if you're willing to do it. And he wanted to do it. So we went ahead and did the surgery on both legs at the same time, which I normally wouldn't do, but because he was from out of the country, I thought we should do that. And after the surgery, on his first post-op visit, when he came to see me, he said, Dr. Bregman, I already feel a little bit better. I don't want to get my hopes up too much, but I'm excited. And so he also told me, which I'm glad he told me after the fact, was that if this surgery did not work for him, he was going to kill himself. And I had no idea. That's, but that just tells you how bad this condition can be. Right. And living with it for so long, just like these complex regional pain syndrome patients, the wear and tear on your mind and your psyche is just so bad. So fortunately, he didn't get, 100% relief, but I asked him last time I spoke to him, which was over a year ago, to follow up with him. He said he was about 75% better, and he's only taking a light dosage of one of the medications. So he was able to get off all the stuff that was making him sick, and he now sleeps about 5 to 6 hours a night and gets some reasonable sleep. So, it gave him his life back. And so that was just an amazing story to me. And when he went back to Australia, he got quarantined for 2 weeks in some dormitorium or something. He couldn't even go back home. And so he had difficulty getting his medication because he had to wean off of it because he had been on it for so long. So there was some troubles he had to deal with while he was in quarantine, but ultimately he did fine.
Wow.
Yeah, it's I've had the restless leg syndrome for the last 26 years now. I got it right about 19, 20 years old. I've had it ever since. And it's spread from my legs all the way up to my arms. And
you can have entrapment anywhere, whether it's your legs or your arms. And, honestly, you should probably be evaluated for nerve entrapments, at least to see if you have them. But again, it's not always classic. So, it just depends on how much you can take. And, if you're, as you probably know, the Mirapex that you're probably taking or have been on, it's not great for you.
Well, I haven't really been taking actually any medication as far as prescribed medication. What I have been doing is taking Tylenol, and usually about a half hour later, it kind of subsides a little bit because it does like a little muscle relaxers, or sometimes you have like a glass of wine and it relaxes you. So then you're able to fall asleep for at least a few hours.
Well, that's good. I mean, you probably have obviously not as severe as cases that other gentlemen did. And again, everybody's different, right? Everyone's thing is always different. And so that's what makes practicing medicine and surgery so difficult. And they call it practice because there's all nuances that we don't even understand genetically and underlying metabolic issues that, affect it. And that's why, when I do exactly the same procedure on 10 different people, you get 10 different kind of results.
Right.
Yeah, exactly.
And how does restless leg syndrome and CRPS come into play? Does the restless leg syndrome trigger the CRPS, or how does that work?
Well, in general, those two entities are completely different. They should not. I'm sure some transect somewhere and collide, but they're really two different entities. So someone with restless leg syndrome, let me put it this way, I've never seen anyone with restless leg have complex regional pain syndrome, but I bet you there's people with complex regional pain syndrome that probably have restless leg syndrome. So I haven't personally seen one yet, and they're not really tied together, but I'm sure that there are people who exist who have both.
Wow.
So with your experience, what have you come across other patients with CRPS? You don't have to tell the names and stuff, but just the general stories. What kind of other stories do you have with patients with CRPS?
Well, unfortunately, most of them are not good, right? Because CRPS is just not enough research and study is being done to really figure this out. And it may be that it's because oftentimes, this is a entity that is started by typically some innocuous little thing that grows into this raging pain machine that embeds itself into your brain. Your brain can't really get out of its way to heal it. And as a peripheral nerve surgeon of the lower extremity, my job is to be able to tell people that, it used to be if someone has CRPS, complex regional pain syndrome, that you don't ever operate on them. You'll make them worse. That was dogma for many, many years. And the reality of that is that sometimes the very thing that's causing their CRPS is, let's say, a pinched nerve or an injured nerve somewhere. And so if you can go fix that, then maybe their CRPS goes away. And so now with things that we're doing perioperatively, like using ketamine and TMS therapy and other things that can sort of relax the brain a bit and kind of dull down the surgical procedures a bit, we can have a little more positivity about going in and operating on people who do have complex regional pain syndrome. So my experience has gotten better over the years, but it's still, frustrating to treat the condition because there's so many things underlying that could be causing it. As I mentioned earlier, that, doing one procedure on this person with CRPS may not work for another person with, similar symptoms because either their mental status is different or their genetics is different or the mechanism of action is different. So again, there's so many things, but one of the more promising things that we do have are these nerve stimulators, and not only is there stuff that you can do up in the spine, but also these peripheral nerve stimulators that, again, if you can sort of get to the origin of where these nerves are and place a little wire next to them that interferes with that ability for that nerve to send the pain signal to the brain, then, you can hopefully reduce that person's pain. And, when someone has CRPS, they always often mention their pain level is very high. Very few of them say my pain level is a 3 or a 4. They usually say it's an 8 to a 12 out of 10. And so if you can take them from an 8 to 12 down to a 6 to 7, that's a win. And that's what we tell people when we're doing these things, that listen, it's very unlikely we're going to get you pain free, but if we can get you 50% better as a maximum goal and get you off some of the meds you're on and allow you to function better, would you like to do that? And almost all of them will say yes.
Now, are there a lot of studies done on CRPS that you know of? Because a lot of, what we just learned within the last few weeks, it seems like a lot of it is relatively new, quote unquote, within the last 20 years. So do you know of a lot of medical studies that's done on CRPS?
I actually don't. And part of the reason I don't is, in my world, I actually don't see a ton of complex regional pain syndrome patients. They're predominantly seen by, quote, pain management doctors. And, it would actually be a service to those patients to be evaluated by someone like me, just to see if there is something that there's a generator of that pain that may or may not respond to some sort of surgical procedure, whether it's more invasive or not. But there is not a lot of research being done, and why is that? Part of it is it's so all over the map as far as the degree and what's involved, and we still don't know enough about it. But also money. It's almost always money. If there's no money to be made studying it, then it's probably not going to get studied. And the amount of people with CRPS versus as an example, people with high cholesterol is dwarfed. So how much money is spent on treating people with cholesterol problems, as by all the commercials that you see. So It's unfortunate that that's the case, but that's the reality.
Yeah.
So now, in other topics that Deborah and I we were talking about in her first episode, she talked a lot about holistic aspects and diet and nutrition. So, can you talk to us about how diet and nutrition may pertain to podiatry and medicine?
Yeah, I'm very glad you asked me that question because I've been very into those two subjects, diet and nutrition, which go together sort of, because without that foundation of having that fuel that you're putting in your body to help your body out, then everything any doctor does is not going to work as well. And if you're really taking it to the extreme where someone has just a really poor diet where they're eating fast food every day in large quantities and lots of sugar, that creates inflammation in your body. Mm-hmm. And so if you have inflammation in your body, inflammation is the root of all evil. And inflammation causes heart disease, it causes hypercholesterolemia, it causes pain, it causes weight gain, just everything. And so I actually give probably about 75% of my patients get a little sheet that I've made for them that has a lot of resources for them to use to learn about diet and nutrition. And I kind of dialed that down to one page with a couple of books that I recommend to my patients, along with some website resources, and even a website that is for people with food addiction, especially to processed food. So I really try to get that through to people, and most people appreciate it. Every once in a while, I get some patient who's like, I didn't come here to hear about my diet and nutrition. I came here to get my foot fixed. Well, if you weigh 380 pounds, you're never going to get your foot fixed.
Yeah,
so, let's work on that too while we're working on your feet. And, often patients, I think people now understand that weight loss is 90% diet and 10% exercise. People used to think, I got to exercise to lose weight. And the reality is, no, you don't. You could not exercise at all. Maybe just do some strength training and you'll lose just whatever weight you want to lose as long as your diet is good. The exercise is really more for your cardiac health, not really for losing weight.
What I found personally, and I know this is more of supposed to be, CRPS and nerve, podcast, but my personal experience, and when you're talking about nutrition and diet and how it affects your overall health, it is very true. And inflammation, I've suffered with arthritis. I'm 44 years old. I started getting it in my mid-20s, and my grandma had it, my mom had it, so it's all in my genes, but I didn't know what was causing it. So I started taking some herbal supplements, and that takes away inflammation, and that helped me so much. And then now I just recently discovered ginger. Drinking ginger tea in the morning, it even helps more because it decreases the inflammation, so when Deborah was talking about holistic aspects of that, it excited me because in common knowledge, like when I was growing up, going to school, they didn't teach us about nutrition in detailed. And now, the last 20 years, it's been changing. 20 years, 10 years ago, it all changes. So I'm glad that now we're talking more about holistic aspects and how it all comes into play. And of course, your diet and nutrition does affect your overall body health. So the fact that you're talking about it, it's encouraging because I don't know a lot of doctors. I mean, they may say towards the end of your evaluation, as a patient, you need to lose like 15, 20 pounds, but then they just kind of peter off after that, but then we got to address this with the medication and whatnot. So I'm glad that you agree to that when you're talking to patients because it does affect them. Like you were saying, if you're 400 pounds, you're not going to be able to feel better on your feet, so you do have to lose weight. So that's a good thing that you talk about that.
Yeah, interestingly, something I never thought I would be getting into is I'm actually, for people who have difficulty losing the weight, let's say they've made a real good effort to try to lose that weight with the information that I've given them. And they're like, Doc, I've done everything you said and I just can't get rid of this weight. I've now started using some supplements like semaglutide to help them lose weight. That's something that has to be injected subcutaneously. And you see these commercials for the Ozempic, which is basically what that is. And so I started using that in people who are sort of hit a plateau and they can't get past it. Not as something permanent, but just something they can go on for, let's say, 4 months. to get them over that hump, and then, carry on with their program. It's all tied together. You can't just do one thing. There's no shortcuts. This is not a shortcut, but it's for those people that, need that extra boost because their metabolism, there's something wrong with it. And so I don't mind using a drug like semaglutide and some other things to help enhance the weight loss as long as it's relatively safe. I'm not into using amphetamines or things of that nature to help people go down that road. And I'm really trying to avoid, any sort of stomach stapling or gastroplasty, if possible. Sometimes it's not possible, but, those are things that, can have, problems down the road. So we're always trying to do it naturally whenever possible.
Yeah, that's always a good thing. And since we're on the topic of basically the holistic type of thing, what is your views on holistic medicine compared to the traditional medicine?
So I like a mix of them. I would so holistic for us is really more or less meaning like Eastern medicine, right? The Chinese, Asian medicine, Indian medicine, stuff like that. Mm-hmm. And they're obviously doing something right? Our way isn't the only way. And in fact, our way really, if you think about it, is just a generation of money for the pharmaceutical companies. That's really what most of our you go in, the doctor sees you, writes a prescription, go get it filled. So the pharmaceutical companies fund all these so-called trials to support their positive outcomes. And I know for a fact that, they will never publish negative stuff about their products. If they come out with a product, if they come out with a drug that doesn't work, you'll never see it advertised. They only, this is common sense, but they only advertise and publish things that, quote, work from the studies they produced. Right. And oftentimes, 10 years later, the studies are proven ineffective, or they were, there's something not kosher about them. So my feelings are that you should always try to, I would prefer to be more holistic in my approach to treating people whenever possible. And that, you fall back on things like prescribing medications that have side effects. Every drug you get is a side effect. Whether it's positive or negative, that's the important thing. And then even with surgery, I do not push surgery on anyone. There are some times where I look at something, I say, this needs surgery. You have to have surgery if you want this fixed. There is no option B, but I am definitely, as I've gotten more into practice, pro-conservative care, avoid surgery if you can, because every time you take that knife to someone, you're creating scar tissue. Right. And that scar tissue may or may not, cause a problem. So, there are obviously times where you have to do surgery, where someone has a tumor, or, they broke their bone, stuff like that. But for elective stuff, I do try to avoid it whenever possible. And in my world, with nerve stuff, with something like tarsal tunnel syndrome, which is basically like the carpal tunnel syndrome of the wrist, which is tarsal tunnel syndrome is almost as common as carpal tunnel syndrome, but people don't know enough about it, and they misdiagnose it quite often. But that's when I diagnose that, probably 80% of the people that I diagnose with it wind up having surgery because they just don't respond to conservative therapy.
Now, talking about the holistic aspects, do you suggest a lot to your patients physical therapy? Does that seem to help them? Or are the patients that you've seen, even the ones with CRPS, are they much too severe to the point where physical therapy would not help them?
So if I see someone who has just developed complex regional pain syndrome, like within the first week or a month, I think physical therapy in the right hands can be very helpful. But if it's long-standing, I don't really find it to be that helpful. For my post-surgical nerve patients who need to get moving, and that's one of the things too, a lot of surgeons, after they do some nerve surgeries, you want to get that nerve gliding and moving right away. If it don't, it gets stuck in the scar tissue. And these surgeons incorrectly tell their patients, I need you off your foot for 2 to 3 weeks, and you're in a cast or a splint. And that is literally the worst thing you can do to someone who just had a nerve surgery where you need to keep it moving. And I don't understand the rationale for this from their viewpoint. I mean, I guess they're trying to avoid, swelling and the stitches popping open. But, you don't have to have them walking all the time, but you should get them moving as quickly as you can. So I think PT can be a big part of that. And sometimes the patient can do it on their own, like go walking in a swimming pool. As far as for complex regional pain syndrome, again, I think it's variable. Some people benefit from it and some people would get worse.
When you say about moving and moving around after surgery, I agree with that too, because I've had 2 surgeries in the past, and right after the surgery, it's important to get moving around because, like you said, the blood flow and everything. And I found that I've actually healed a lot faster, and I was able to get off the pain medication quicker. And, I was on, the prescription pain medication for like a day or 2 after surgery.
Yeah, they wanted you on it for 2 weeks.
2 weeks. And then, but once I was moving around within that short amount of time, then I was able to decrease the prescription medication, pain meds, and then onto the generic over the counter. And so that helped me heal a lot faster. I wasn't as, constipated from the pain medication. So it helped my healing process, and along with diet and good nutrition. So it's good that you bring that up and you talk to your patients about that.
Yeah, that's all tied together. Again, whatever we could do to give you the best outcome, we want to do that. And just like when I don't know when they started doing it, but orthopedic surgeons who do knee replacement surgery, you're moving at day 1. And so why wouldn't you do that with nerve surgery? It doesn't make sense. Why? Okay, well, we'll do it for this, but we won't do it for that. I don't understand that thought process, but
yes.
Yeah. And I wish there was a lot more, doctors in the world, just like you know, that think the same way you do. Cause a lot of these other doctors are like, whoa, come on, man. I mean, geez.
Yeah. You have more, you have a good bedside manner. You seem very open to learning new things, and you also take time to listen to your patients, and you also have the sympathy and empathy towards your patients, which the doctors that I've come across, they don't seem to have that as much, because they just seem to want to cram the patients into their consultation time, get them in and get them out. Especially my own personal excuse. I've actually had doctors that have their hand on the doorknob as they come in to talk to me real quick.
And one leg out the door and one leg in the door.
Yeah. So talking to you, Dr. Bergman, is such a pleasure. And I'm so happy that you took the time to talk to us on our podcast. Now, for those that want to reach Dr. Bergman's office, he is at the Bregman Foot-Ankle and Nerve Center in Las Vegas, Nevada. They could be reached at www.Bergman, is it Face? F-A-N-C-E? Am I pronouncing it right?
So I know it's a hard thing to pronounce, even my name, right? So it's Bregman Fance, like fence, but with an A. So FANCE.com.
Okay. I apologize for that. And you can call him at his office number at 702-703-2526. And now for the next episode in the CRPS Warriors Foundation series will be airing on Saturday, April 22nd, which will feature Dr. James Wilton. So Dr. Bergman, thank you so much for your time. We appreciate you.
My pleasure. And it was a pleasure speaking with you guys. And I hope that people listening can learn a little something and get some education, and hopefully we can just keep moving forward with this horrible condition of this complex regional pain syndrome. And maybe 5 years from now we'll have a much better understanding of, and hopefully helping these people out who are suffering.
Yeah.
Yes, and we'll definitely keep your number on our own personal Rolodex if in case Mike needs to contact you in the future for consultation. Hopefully you'll accept our insurance, so we'll definitely be in touch, hopefully.
We'll figure it out one way or another.
Yes.
Yes, sir.
Thank you so much for your time. Have a good day.
Thanks, you too. Take care.
Bye.
Bye-bye.
Thanks for listening to the Mike and Phoebe Show on Alternative Twist Radio. If you missed any past episodes, just search the Mike and Phoebe Show or Alternative Twist Radio on any major podcast app.